Pleural effusion.
Before we move on to what the disease is, we have to know about what the pleura is. So, as you are knowing, pleura, it is the covering of the lungs and as well as the thoracic cavity. Two types it is told, parietal pleura and visceral pleura, and the space between the parietal pleura and the visceral pleura, it is called the pleural space. The pleural cavity is always bathed by pleural fluid. This fluid is exudated by the visceral pleura and is absorbed by parietal pleura. Approximately 1000 ml of this fluid is formed per day, and any disturbance in the balance of secretion and absorption may result in accumulation of fluid in the pleural, and this abnormal accumulation of fluid in the pleural space is called pleural effusion. So, pleural effusion is defined as abnormal accumulation of fluid in the pleural space, that is, the space between parietal and visceral pleura. Pleural effusion types, it can be classified into two groups, transudates and exudates. Transudates develop when there is either excessive production of pleural fluid or the reabsorption capacity is reduced. It is clear with faint yellow tinge and no odor. And most common cause of transudate pleural effusion is congestive cardiac failure. Exudate occurs when the pleura is damaged by trauma, infection, or malignancy, and it is caused by blocked blood vessels or lymph vessels. And the causes for this condition, it is told like it can be trauma, it can be due to bacterial pneumonia, tuberculosis, congestive cardiac failure, pulmonary infarction, etc. And the clinical features include breathlessness, dyspnea, decreased movement of chest on the affected side, absent or diminished breath sounds, and on examination on percussion there will be stony dullness. Auscultation reveals absent or decreased vocal resonance and fremitus. And in cases of massive effusion, the mediastinum is shifted to opposite side, causing compression to the opposite lung. And in this condition, the investigations suggested are X-ray and pleural aspiration. And X-ray of chest PA view shows area of whiteness, as shown in this slide. You can see area of whiteness, and that is the finding which is evident in the X-ray of chest PA view, and this helps in the diagnosis. And about the treatment, as we have already told about different causes for pleural effusion, first thing is treat the cause, and if there is infection and all, we can go for antibiotics. And another procedure is thoracocentesis. And what thoracocentesis is, this procedure, it is an invasive procedure to remove the fluids or air from the pleural space. It can be done for diagnostic purpose or for therapeutic purpose. And the procedure is indicated in case of pleural effusion, empyema, thoracic, etc. And in patients who are non-cooperative and the patients with coagulation disorders, this procedure is contraindicated. And the procedure, how it is, first the position, as you see in the image, it should be in sitting position, that too leaning forward over a wooden support. And the site should be tip of the scapula with 7th intercostal space. And how the procedure is, that is, it should be done carefully after localization of the effusion by X-ray photograph. And after giving local anesthesia, the appropriate needle is directed just above the superior border of lower rib of the 7th or appropriate intercostal space. And then the needle is penetrated through skin, intercostal muscle, and parietal pleura till the fluid is reached. During aspiration of the pleural effusion fluid, the needle tip should be directed upwards. That is, to avoid the damage to the diaphragm, the needle tip should be directed upwards. And it is told like aspiration should not exceed 1 liter, because there can be a risk of development of pulmonary edema. But in case of massive pleural effusion, 1500 ml should be aspirated in first attempt. Generally, the removal of available fluid usually presents with no difficulty, but sometimes after complete evacuation of the fluid, there can be pain, discomfort, severe cough, etc. Other complications include infection, sudden vagal shock, blood tap, etc. That is thoracocentesis. And next is pleurisy. Pleurisy, it is known as pleuritis also. So, as the name suggests, it is the inflammation of the membranes that surrounds the lungs and lines the chest cavity. That is the pleura. So, pleurisy or pleuritis is the inflammation of the pleura. And what happens in this condition is that uh, in in a normal condition, what happens is the two pleura will be having a smooth gliding, but certain due to certain reasons in this condition what happens is the pleura will be rubbing together. That is, there will be rubbing together of the pleura, and that causes inflammation of the pleura, and ends up in this condition called pleurisy or pleuritis. And the causes which can result in pleurisy or pleuritis is one is viral infections like Coxsackie B virus, adenovirus, influenza, etc. Then bacterial infections associated with pneumonia, tuberculosis, etc. Then chest injuries, then cardiac problems like ischemia, pericarditis, then pneumothorax, lung cancer, lymphoma. These are the causes which can result in uh, pleurisy. Then the clinical features which is seen in this condition are sudden, sharp, stabbing, burning, or dull pain that will be present in the right or left side of the chest, and the pain will be felt during breathing, especially when one inhales and exhales. That is the time when the pain is present, and the pain will get worst with deep breathing, with coughing, sneezing, or laughing. So pain is the main feature, and that pain can be sharp, stabbing, or dull pain, and it can be felt either in the right side or in the left side, and that too when the person is inhaling or exhaling, that is during the breathing. And the pain gets worst with deep breathing, coughing, sneezing, and laughing. Other symptoms include shortness of breath, cough, fever, weight loss, and that and all depends on the underlying cause. On examination, pleural friction rub is present. That means pleural friction rub. Uh, that is a finding when the doctor uses the stethoscope to listen to the breathing. The inflamed layers of pleura make a rough, scratchy sound, because as told, the underlying pathology in this condition is that the rubbing together of pleura is happening. Instead of the smooth gliding, there is rubbing together of the pleura. So in this condition, when the doctor uses the stethoscope to listen to the breathing, the inflamed layers of pleura make a rough scratchy sounds. As they rub against each other during breathing, there will be rough scratchy sounds heard, and that is called pleural friction rub. That can be heard in the examination. And next, about the investigation, chest x-ray and blood test can be done. Chest x-rays may show air or fluid in the pleural space, and the blood test is done to detect the bacterial or viral infection. What is the underlying cause? To detect that, blood tests are being done. Treatment, of course, as told in pleural effusion, treat the cause, then bed rest, then pain is told. So, anti inflammatory agents can be given to control the pain. Then, associated with that, cough will be there. So, codeine based cough syrups can be given to control the cough. And then, as there, the reason can be pneumothorax or pleural effusion. The pleurisy may result mm, as a consequence of this pleural effusion or pneumothorax. So, thoracocentesis can be done to drain the fluid, air, or blood from the pleural space. So, that is the treatment to be given in pleurisy. Next is chest injuries. Chest injuries, when we see, the chest injuries occurs in almost 80% of the incidents. When we take 80% of road traffic in accidents, chest injuries can occur. Then in wounds, about 10% wounds, chest injuries can occur. And those killed in battles and all, in those cases also chest injuries may occur. So the types of chest injuries, it is classified into two: closed and open. And the causes of chest injuries can be group dust, road traffic accidents, industrial accidents, assault with blunt objects, fall from height, crush injuries, stab injuries, gunshot injury, etc. These are the different causes for chest injury. And among the chest injury, the first one or the main one is fracture of the ribs. So fracture of the ribs, it can be single or multiple ribs or single rib can involve in the fracture. And the first and second ribs and the 11th and 12th ribs are rarely fractured. First and second ribs are rarely fractured as they are protected by the clavicle, and 11th ribs are also rarely fractured as they are floating ribs. This condition is more seen in elders and occasionally seen in children as their ribs are more flexible and elastic. And the fracture of the ribs, the common site is the costal angle or the middle of the shaft. And the presentation, the complaints told by the patients will be difficulty and pain during breathing, and more than a lying position, the patient will be preferring a propped up position. The propped up position will be comfortable to the patient more than lying position. And in the fracture conditions, there can be associated rupture of thoracic aorta. Then fracture of lower ribs can be related to injury of liver or spleen. Then fracture of ribs can be related to injury of lung parenchyma, thoracic wall vasculature, etc. And on examination, on inspection, there will be presence of a slight bruising. And on palpation, the local bony irregularity will be present, tenderness will be seen, and crepitus will be palpated. Then compression test will be positive. And investigation, chest X-ray is the choice of investigation, and it is usually confirmatory, but it may miss a hairline crack fracture. And here the treatment, it is the aim of the treatment is to reduce the pain. So analgesics, systemic analgesics can be used. Then local injection, intercostal nerve block can be given. Then assurance, strapping of the chest, intermittent use of velcro belt, rib support, and epidural analgesia with respiratory physiotherapy also can be given. And the complications of fracture of the ribs, that include general complications as well as local complications. General complications include shock, and the local complications include surgical emphysema, traumatic pneumothorax, hemothorax, stove in chest and flail chest, pulmonary contusion and laceration, injury to the heart and pericardium, traumatic asphyxia, injury to the diaphragm and diaphragmatic hernia, injury to the subdiaphragmatic organs like liver, spleen, kidneys, colon, and stomach. First one, the surgical emphysema. It means air in the subcutaneous tissue. Subcutaneous emphysema. There also the patient complains of pain in the chest due to the fractured ribs, and on inspection we can see bruised skin, and there will be swelling over the affected area. Then treatment does not require any treatment as air is usually absorbed from the subcutaneous tissue. X-ray is the confirmatory investigation to be done. That is surgical emphysema, air in the subcutaneous tissue. Next, it is the traumatic pneumothorax, that is air in the pleural cavities thorax, and when it is due to trauma, it is called traumatic pneumothorax. It is of three types: closed, open, and tension. And the clinical features, of course, it include dyspnea, pain, shock, cyanosis, etc. Accumulation of blood in the pleural chest. And next is toe in chest. Toe in chest means it is a rare and complex type of uh, injury where which develops from the extensive localized crushing force, which produces multiple rib fractures. And because of this multiple, be a depression in the chest wall in that region, and that condition is called Stone chest. And another condition is flail chest. That is an injury that occurs typically following a blunt trauma to the chest. And when three or more ribs in a row have multiple fractures within each rib, what happens is that it can cause a part of your chest wall to become separated from the rest of your chest wall. That condition is called, as you see in the image, in a row there can be means three or more ribs in a row have multiple fractures, and therefore a part of your chest wall becomes separated from the sink, and uh, that will cause a depression like uh, means that there will be a floating segment, or there will be an unstable fragment of the chest wall present there, which is having no bony connection. That is what is happening in the flation of the lung and pulmonary laceration. Pulmonary contusion, it's the term used to indicate the consequences of blunt trauma to the lung. That is often it is associated with the fracture of the ribs or sternum. And pulmonary laceration represents greater extent of that pulmonary contusion, and injury to the lung is clearly evidenced by the hemoptysis. Next is injury to the heart and pericardium. That is, the heart may be injured by the penetrating wound. As a result of this fracture of ribs, the heart and pericardium can also get injured. Then, due to crushing injury of the chest, traumatic asphyxia can occur. Then, traumatic rupture of diaphragm, penetrating injuries or crush injuries to the lower chest or upper abdomen can result in rupture of the diaphragm. Then another condition is mediastinal emphysema, where when in this condition what happens is there is escape of air into the mediastinum. It can be either through the wounds of the trachea or bronchi or the esophagus. There will be escape of air into the mediastinum. That is mediastinal emphysema. Then in this condition, the investigation, mainly based on clinical examination, uh, we can go for the diagnosis, and along with the clinical examination, it can be supplemented by chest radiography also, and anterior posterior supine chest radiograph can help for the diagnosis, and it is the simplest initial investigation that can be done. Along with that, ultrasound can be done to differentiate between contusion and actual presence of blood. Then CT scan, uh, that is also a reliable investigative procedure. And the chest drain also can be applied both in terms of diagnostic as well as therapeutic purpose. The chest drain also will help. About the management, depends on the injury. That is, in penetrating injury, it can be managed with appropriate resuscitation and insertion of a intercostal drain. And if a sucking chest wound is present, this should not be fully closed, covered with a piece of plastic closed on three sides to form a one-way valve. And thereafter, an underwater chest drain can be placed. In blunt injury, most bleeding occurs from the intercostal or internal mammary vessels, and some rare cases for these, it requires surgery. And if bleeding does not stop spontaneously, the vessels can be tied off or it can be encircled. That is the management that is based on the type of injury happening. Another important thing is the deadly descent. That means some immediately life-threatening injuries and potentially life-threatening injuries can happen. The immediately life-threatening injuries include airway obstruction, tension pneumothorax, open pneumothorax, massive pneumothorax, cardiac tamponade, failed chest, and potentially life-threatening injuries include tracheobronchial disruption, aortic disruption, rupture of diaphragm, esophageal disruption, myocardial contusion, and pulmonary contusion. Airway obstruction. In case of airway obstruction, early intubation is very important. And in tension pneumothorax, that is when a one-way valve air leak occurs either from the lung or through the chest wall. That air is sucked into the thoracic cavity without any means of escape, and that will be there will be completely collapsing and then compressing the affected lung. So in this case, the mediastinum is displaced to the opposite side, decreasing the venous return and compressing the opposite lung. And the most common causes for this tension pneumothorax are penetrating chest trauma, blunt chest trauma with parenchymal lung injury, and air leak that did not spontaneously close, or an iatrogenic lung injury. And in this condition, the patient will be increasingly restless with tachypnea, dyspnea, and distended neck veins. Clinical examination also will reveal that tracheal deviation. Treatment to be given is immediate decompression, initially by a rapid insertion of a large bore cannula, and then followed by insertion of chest tube. That is the treatment to be given. Then, in case of pericardial tamponade, that is a result of penetrating trauma. There will be accumulation of relatively small amount of blood into the non-distensible pericardial sac. Here also there will be compression of the heart and obstruction of the venous return, and therefore there will be decreased filling of the cardiac chambers during diastole. And here needle pericardiocentesis can be given, and then immediate treatment of tamponade is operative. That can be subsifid window or open surgery, sternotomy or left thoracotomy can be done in this case. And in case of open pneumothorax, that is due to a large open defect in the chest, here air accumulates in the hemithorax with each inspiration, and there will be hypoventilation. Here, initial management can be by giving the closing the defect with the sterile occlusive plastic dressing, and also insertion of chest tube is advised in this case. And massive hemothorax, mainly it is caused due to blunt injury, and there will be accumulation of blood in uh, the hemothorax, and that can be causing to respiratory, compromise the respiratory efforts, and there will be compression caused to the lung. And here there can be, because of the hemorrhage, because of that blood accumulation, there will be shock, and so the hypovolemic shock have to be corrected. Then intercostal drain can be inserted, and as there is hemorrhage happening, initial drainage of more than 1500 ml of blood, or that ongoing hemorrhage can be done, that drainage can be done in this case. Flail chest already we have discussed, and other potentially life threatening injuries, which include the thoracic aortic disruption, that can be a common cause of sudden death after an automobile collision or fall from a great height. And in this condition, we can go for the diagnosis is confirmed by aortography or a contrast spiral CT scan. Initially, the management it is to control the arterial blood pressure, and then aortic stent can be placed, and grafting also can be done in that case of disruptions. Then tracheobronchial injuries, there will be respiratory compromise. In such cases, intubation of the unaffected bronchus can be done and followed by operative repair. Then myocardial injury, blunt myocardial injury, that also there will be blunt trauma which result in myocardial injury, and there echocardiogram will be helping in the diagnosis. Then other injuries include the pulmonary contusion, esophageal disruption, diaphragmatic injuries. These conditions also there will be penetrating injury at the level, and in case of large ruptures, diaphragmatic rupture, if it is large, there will be herniation of the abdominal contents into the chest. And in that conditions or in other injuries which is resulting from the penetrating trauma or blunt injury, uh, the treatment is operative repair of the defect, and proper drainage have to be done, as there is a chance of blood accumulation inside. Proper drainage as well as operative repair can be done here. And another emergency thoracic surgery is also told, immediate thoracotomy, that is in the emergency department, that is to control the hemorrhage, cardiac tamponade or internal cardiac massage. That is emergency sternotomy for anterior mediastinal structures and heart. Then planned thoracotomy for definitive correction of the problem. So two types of sternotomy is told under the emergency thoracic surgery. One is emergency sternotomy, and next one is planned thoracotomy. Emergency sternotomy is for anterior mediastinal structures and heart, and planned thoracotomy for definitive correction of the problem. And the aim of that emergency thoracic surgery or the department is that to perform the internal cardiac massage, to control the hemorrhage, that is the control of hemorrhage from injury to the heart or lung, and to control the intrathoracic hemorrhage from other sources. to control the massive air leak, and clamping the thoracic aorta to preserve the blood supply to the heart and brain. So this is the aim of that particular procedure. Internal cardiac massage, control of hemorrhage, control of massive air leak, and clamping of the thoracic aorta to preserve the blood supply to the heart and brain. And there are different approaches to the contents of the chest cavity as told. Left anterolateral thoracotomy in case of left lung and hilum, then thoracic aorta, then left side of heart, lower esophagus, etc. Then right anterolateral thoracotomy in case of right lung and hilum, then esophagus vein, superior vena cava, upper esophagus, then thoracic trachea, then median sternotomy, anterior aspect of heart. And so depending upon the contents of the chest cavity, different approaches are told: left anterolateral thoracotomy, right anterolateral thoracotomy, and median sternotomy. This is what is about the diseases of chest. So mainly the syllabus it is focused on these three. So pleural effusion, pleurisy, and chest injuries. These are the three main aspects which is dealt here. So pleural effusion, as already told, that is the accumulation of fluid in the pleural space, that is between the parietal pleura and visceral pleura. There will be accumulation of fluid, that is pleural effusion. And two types it is told: transudates and exudates. And causes, we have seen clinical features, the investigation suggested, and treatment. Treatment includes thoracocentesis, which is an invasive procedure to remove the fluid or air from the pleural space. It can be for diagnostic or therapeutic purpose. And the procedure it is being told. Then it is about the pleurisy. So pleurisy, also known as pleuritis, is the inflammation of the membranes that surrounds the lungs and lines the chest cavity. This is due to the rubbing together of the pleura inside. And causes, we have seen clinical features on pain was the main clinical feature. And along with that, on examination, pleural friction rub was seen. Treatment, cause have to be treated to control pain. Anti-inflammatory drugs have to be used. Then to control cough, codeine based cough syrups are told. And thoracocentesis can be done here in this condition also. Third one was the diseases of means chest injuries, and two kinds: closed and open. Different causes we have seen: road traffic accidents, industrial accidents, assault with blunt objects, fall from height, crush injuries, stab injuries, gunshot injury, etc. And among that, rib fracture was the main thing we have seen. And rib fracture, it can be single or multiple. And first and second rib, and 11th and 12th rib, it is rarely fractured, first and second rib, because it is covered by the clavicle, and 11th and 12th ribs as they are floating ribs. Main complaint will be difficulty and pain during breathing. And the patient will be feeling comfortable in propped up position than lying position. Chest x-ray was a choice of investigation. And as treatment, analgesics, intercostal nerve blocks, strapping, rib support, etc. was told. And as a result of this chest means rib fracture, so many complications were told: surgical emphysema, then pneumothorax, hemothorax, stove in chest, flail chest, contusion of lung, injury to the diaphragm, injury to the heart and pericardium. So many complications we have seen. Then other than that, the chest injuries can result in immediate life threatening and potentially life threatening conditions, that also we have seen. And treatment, depending upon the type of injury, depending upon the impact it is caused, there are different treatments told. And based on the contents of the chest cavity, different approaches to the contents also we have seen, that is left anterolateral thoracotomy, right anterolateral thoracotomy, and median sternotomy. So that is about the diseases of chest. Now next is about diseases of spine. In the context of diseases of spine, we will see about Pott's disease, ankylosing spondylitis, and IVDP. So first we will see about Pott's disease. Pott's disease is also called TB spine, tuberculosis spine. And about TB spine or POTS disease, its incidence, it starts between the 3 to 5 years of age. uh, and the commonest site of affliction, it is told that in the spine, lower thoracic T10 or thoracolumbar junctional region is the commonest site of affliction. And about the etiological agent, POTS disease or TB spine is caused due to uh, the bacteria, that is Mycobacterium tuberculosis. It is a rod shaped, non spore forming, thin aerobic, weakly gram positive bacterium, and that is the etiological agent for this condition, Mycobacterium tuberculosis. And the predisposing factors, it include malnutrition, poor sanitation, overcrowding, close contact with the TB patients, multiple pregnancy, immunodeficiency state, etc. And the commonest we have seen in the spine, cervical, cervicodorsal, dorsal, dorsolumbar, lumbar, lumbosacral, all the sites are prone to uh, the POTS disease or tuberculosis, but the commonest site is thoracolumbar junctional region or the lower thoracic region. And the types, different types of um, vertebral tuberculosis it is mentioned. They are paradiscal, central, anterior, and posterior. The as you see in the image, the same way. First one is paradiscal, then it is central, then it is anterior, and last one is posterior. So first one, paradiscal, this is the commonest type. In this, the contagious areas two adjacent vertebrae along with the intervening disc. As you see in the image, the two adjacent vertebrae and the intervening disc, they are affected. So, in the paradiscal, which is the commonest type, the two adjacent vertebrae along with the intervening disc are affected. And next one, in the central, the body of the single vertebrae is affected. And that will lead to early collapse of the weakened vertebra. A single vertebra is being involved and its body is getting affected in this type, central type of vertebral tuberculosis. The body of the single vertebra is being affected, and there will be collapse of the weakened vertebrae, and the nearby disc will be normal in this condition. Third one is the anterior type. Anterior type, what happens is the infection is localized to the anterior part of vertebral body. As you see in the image, the anterior part of the vertebral body is being affected. The infection is localized to the anterior part of the vertebral body. And from the anterior part, the infection spreads up and down under the anterior longitudinal ligament. So that is what is happening in the third type, that is the anterior type. And last one, it is the posterior type. Posterior type, what happens is the posterior complex vertebra, that is the pedicle, lamina, spinous process, and transverse process. That is the different parts of the vertebra. Pedicle, lamina, spinous process, and transverse process. These are getting affected. That is the fourth variety. So, types of vertebral tuberculosis, it is of four: paradiscal, central, anterior, and posterior. Paradiscal is the commonest type, and there the two adjacent vertebrae along with the intervening disc are affected. And in the central type, the body of the single vertebra is being affected. And in anterior one, the infection is localized to the anterior part of vertebral body. And the posterior one, the posterior complex vertebra, that is the pedicle, lamina, spinous process, and the transverse process is affected. These are the types. Next, about the pathogenesis of TB spine. What happens is that this is the step one. In the step one, the bacilli from primary focus, that is through the blood, means the TB of spine is always secondary. That is, the bacteria will reach the spine via the hematogenous route. And when we see the pathogenesis, the bacilli from the primary focus, as it is a secondary condition, from the primary focus, the bacilli have to reach the disc space. So the first step is the bacilli from the primary focus uh, will reach the disc space through the bloodstream. You can see in the picture, the first image, the infected disc is being shown. So the bacilli have reached from the primary focus to the disc space through the bloodstream. That is the step one. Then Once infected, what happens? The soft nucleus center and the fibrous annular wall weakens and it decays and it gets collapsed. As you are seeing, the thickness is getting reduced. That is why, because the soft nucleus center and the fibrous annular wall gets weakened, it gets decayed and collapsed. So the space is getting reduced. And so as the because of that, what happens? The disc uh, means cause the disc to close, squeezing down on the nerve root, and there will be pain. Because of this weakness and decaying and collapse of the nucleus center and fibrous annular wall, the disc will close and there will be squeezing down on the nerve root, which results in pain. So you can see in the image the pinched nerve root. That is the step 2. And step 3, what happens is the infection spreads to the vertebral bodies. So from the disc what happens, it is infecting the vertebral bodies. The bones are getting affected. Above and below the disc, the vertebral bodies are getting infected. That is the step 3. And in step 4, the bone weakened by the infection collapses. As you are seeing, the structure has change. There will be collapsing of the bone which is weakened by the infection, because there will be weight of the human body. Because of the weight, it is getting collapsed. Already the bone is weakened, and due to the weight of the human body, what happens? The bone is getting collapsed. That is the step 4. And step 5, what happens? The deformed spinal column means, because of this collapse of the vertebral body, there will be deformation happening to the spinal column, and that deformed spinal column will compress the spinal cord. And when the spinal cord is compressed, what happens? There will be functional impairment. So that is step 5. And in step 6, what happens is that over the time the deformed vertebrae heal and fuse, but this may further compress nerve roots, causing pain and neurological deficit. So that is the pathogenesis of PV spine. So first, the bacilli from primary focus reach the disc space through the bloodstream. Once it is infected, the soft nucleus center and fibrous annular wall weakens, decays, and collapse. This causes the disc to close, squeezing down on nerve root, causing pain. The infection spreads to vertebral bodies above and below the disc. The bone, weakened by the infection, collapses under the weight of the human body. The deformed spinal column compresses the spinal cord, producing functional impairment. And over time, the deformed vertebrae heal and fuse, and this may further compress the nerve roots, causing pain and neurological deficit. That is what is the pathogenesis of LV spine. The clinical features, two stages it is told. Means from the pathogenesis we can understand that there are two stages: active stage and healed stage. And mainly the clinical features are, there will be pain at the site or along with the spinal nerves, which become worse during standing or jolting. Stiffness of joint due to painful movement and muscle spasm. Swelling will be present. Attitude will be in the upper thoracic TB, typically military attitude, that is with raised shoulder, which is drawn backwards. That is the military attitude, and that is to avoid the sudden jerk. That will be the attitude shown by the patient. Then tenderness and rigidity of spine will be present. Weakness and decreased power in the limb muscles, and there will be altered sensation also. Coin test, that is there will be an inability to pick up a coin, that will be positive in this condition. And other features, that is the constitutional symptoms or general features like loss of weight, poor appetite, general weakness, lassitude, evening rise of temperature, these also will be present in this condition. And on examination, the aim of examination is to pick up the findings suggestive of TB, to localize the site of lesion, to find any skip lesions, and to detect any associated complications. Physical general examination is to detect active or healed primary lesion. The patient may have some other systemic illness also, so that should be done. Physical general examination. Gait, always the patient walks with short steps. That is, as we have already told, the attitude, it will be military attitude, that is to avoid jerking. Similarly, the gait also will be the patient walks with short steps in order to avoid jerking the spine. Attitude and deformity, we have already told, there the stiffness will be there, that straight neck will be presented. Then paravertebral swelling, means mainly in tuberculosis, it will be a superficial fold abscess will be present as a swelling on the back along the chest wall or anteriorly. Then tenderness will be present, movement will be limited. And neurological examination should be done of the limbs, because depending on the site of the TB, it should be performed. And that is about the clinical features and examination. And the investigations which help in the diagnosis is plain radiograph, CT scan, MRI, bone scan, etc. Then lab studies, tuberculin skin test, which will help in the diagnosis. Then ESR will be markedly elevated. Then ELISA has a reported sensitivity of 60 to 80%. PCR, such kind of lab test can be done. That also will help in the diagnosis. And then it is about the treatment. Aim of the treatment is to achieve healing of disease and to prevent, detect early and promptly any complication like paraplegia. That complications have to be detected and prevented. Then rest, bed rest for pain relief and to prevent further collapse and dislocation of diseased vertebrae. For that, bed rest have to be advised. And for cervical spine, based on the area which is affected, uh, collar or support can be given. For cervical spine, Minava jacket and collar can be used. Another thing is building up the patient's resistance, as it is a infection which is causing the condition. The resistance have to be taken care. So building up of patient's resistance, that have to be taken care. Then ATT, anti-tubercular drugs treatment have to be followed. Then if there is sinus and all present, then antibiotics can be given. Then if there is bed sore or any other comorbid conditions are there, that care have to be done. And mobilization gradual, means as there is gradual improvement, sit and walk, the spine is supported with collar, brace, or what means based on the uh, site of infection, that can be done. And if we see the conservative treatment and the surgical treatment, conservative treatment, the first line chemotherapy is the bactericidal drugs, mainly isoniazid, rifampicin, streptomycin, and pyrazinamide. And bacteriostatic drugs like ethambutol, that also can be given. Then other drugs like amikacin, kanamycin, ofloxacin, those also can be suggested. And surgical treatment, mainly it can be decompression, debridement and decompression, or anterior transposition of the cord, and laminectomy. These are the different surgeries told. So that is about what spine or PB spine. Next condition is ankylosing spondylitis. Ankylosing spondylitis, this is a chronic progressive inflammatory disease of the sacroiliac joints and the axial skeleton. It is associated with HLA-B27 gene. So it is a traumatic disease of unknown cause, and it primarily affects the backbone or spine. The main features of ankylosing spondylitis, it is there will be chronic inflammation in the axial structures. As I have told, axial structures, the sacroiliac joint, spine, anterior chest wall, shoulder, and hip. And also there will be possibly large peripheral joints, mainly at the lower limbs. It will be included. There will be bone formation, particularly in the axial joints, and there will be presence of HLA-B27. The incidence, it is the male is to female ratio is 10 is to 1. So it is more common in the males, and the age group more, it is more prevalent in 15 to 35 years of age. Two types of ankylosing spondylitis, it is told, true and false. True means due to intra-articular lesion, and false due to extra-articular lesion. True ankylosis is again told as fibrous ankylosis and bony ankylosis. Fibrous means after damage of articular cartilage, fibrosis occurs between the two articular surfaces. So, after the damage of articular cartilage, fibrosis is happening between the two articular surfaces. That is true. We have told already two types it is told true and false. True is due to intra-articular lesion. This true ankylosis is again told as fibrous ankylosis and bony ankylosis. And fibrous, after the damage of articular cartilage, fibrosis is occurring between the two articular surfaces. And this limits the movements of joints, and that is what is happening in fibrous ankylosis. Bony ankylosis means due to the damage to articular cartilage, trabecular trabecle laid between the articular surfaces. In fibrous ankylosis, fibrosis was happening. In bony ankylosis, bony trabeculae are laid down between the articular surfaces. And here, no movement is possible at the joint. That is about true ankylosis. False ankylosis, lesion of extra results in the limitation of movement of joints, and that can be contracture skin, fascia, secondary to burn and all. This can occur. And the involved here is uh, the initial inflammation of the joints is followed by synovitis, arthritis, and cartilage destruction. Then fibrous and later bony ankylosis happen. The joints commonly affected, as told earlier, it is sacroiliac joints, spine, hip and knee, and manubrium sternum. That is the areas of affliction. And about the clinical features, there will be vague symptoms like malaise, fatigue, loss of weight, chest pain, etc. Then early morning stiffness, chronic low back pain, that can be without buttock pain. Then inflammatory characteristics occurs at night, sleep disturbance, then limited lumbar motion, anorexia, malacia, low grade fever, weight loss, fatigue, all those will be present. On examination, patient has a stiff spine, that is like bamboo spine, and loss of movements will be evident. And the test it is told flesh test, that is the cervical spine involvement is tested by asking the patient, as you see in the image, the patient is asked to touch the wall with the back of the head without raising his or her chin. So if the chest expansion is less than 5 centimeter, involvement of thoracic spine is suspected. Similarly, the Schauber's test means to test the range of movements. These kind of tests are done, and on detailed examination, we can find out the limitation of movements or loss of movements. And in this case, pain is worst at night or early morning, and after walking or after some exercise, this pain will be reduced. On examination, tenderness will be present at the sacroiliac joint, and SLR test, that is when the patient is asked to lift the leg up with extended knee, there will be pain at the sacroiliac joint, that is the SLR test also will be positive. Investigations, X-ray. X-ray of spine. Bamboo spine appears with loss of lumbar lordosis, an MRI, CT scan, and several lab tests like CRP, ESR in the blood samples. These also can be used, means they also can help in the diagnosis. Treatment, general measures, patient and family education have to be done. Then smoking, if it is present, that have to be avoided. Then regular exercise like swimming, that can be promoted. Then physiotherapy, spine exercise with deep breathing also can be done. Then conservative therapy, it is rest have to be advised. Then drugs like phenylbutazone, then radiotherapy as palliative measure. Those are the conservative therapies. And surgery, spinal osteotomy to correct the spine. Then total hip replacement for hip ankylosis. Then total knee replacement of knee ankylosis. These also can be done. And other drugs, local steroid injections, and in case of inflamed joints and all, that will be helpful. Then weight bearing, that have to be beware of. Then NSAIDs, other systemic steroids. Then means physical therapies like daily workouts, right posture, those also have to be encouraged. That is the treatment as such. that is about ankylosing spondylitis. Next one is intervertebral prolapse. Intervertebral prolapse, as you know, it is the means the spine or the backbone. It is comprised of number of vertebrae. That is, they are placed over one another with support of inner vertebral disc. And these discs act as shock absorber for spinal column and provide mobility between the bodies of vertebrae. So, and this disc is filled with the pulpy matter and then it is surrounded by fibrous sheath. So that is the uh, uh, normal structure or the anatomy how it is. And when the gap between the two vertebrae is reduced due to some external or internal reason, the inner matter, that is the disc matter, will be compressed and it will be prolapsed at the softer part of the sheath. So that is what is happening. From the normal anatomy, there will be derangement when there is any internal or external trauma happening. And this protrusion, that is the protrusion of this pulpy inner material of the intervertebral disc through the fibrous outer cord, and that causing pressure on the adjoining nerve roots, ligaments, etc. That is called IVDP or intervertebral disc prolapse. So in normal conditions, the spine or backbone, which is comprised of number of vertebrae, which is placed one over the other with the support of inner vertebral disc. With this disc act as shock absorber for spinal column, and it will provide mobility between the bodies of vertebrae. And the disc is filled with the pulpy matter and it is surrounded by fibrous sheath. And when the gap between these two vertebrae are reduced due to any kind of reason, what happens? The inner matter is compressed and prolapsed. And this prolapsed matter will cause pressure over the adjoining nerve roots and ligaments, and it will give rise to pain. So this protrusion of pulpy inner material of the intervertebral disc through the fibrous outer cord, causing this pressure on adjoining nerve roots or ligaments, etc. This is called IVDP or slip disc or intervertebral disc prolapse. Uh, the causes The causes for this IVDP can be external or internal as told. External means trauma, which is common feature in athletes, potters, trekkers, etc. Internal, it can be overweight, less toned muscle, thin body, hyperfunction of backbone, abnormal growth in vertebra. Means this kind of conditions will give rise to pathogenesis like lumbar strain, nerve irritation, lumbar radiculopathy, bony encroachment, etc. And in addition to that, physical illness, emotional stress, swelling of the pulp matter due to absorption of fluid, then disc degeneration. These also can lead to IVDP. So that is the other causes. And the commonest site is the lumbosacral region in 80%, and the disc between L4, L5, and L5S1. And the other site which is common is cervical spine, that is the disc between C5, C6 and C6, C7. Two types are told: posterolateral, which is the common one, and next one is central posterior. And the clinical features, there will be low back ache in distribution of the root, which gets aggravated by straining, coughing, twisting, stooping, etc. Then pain radiates along the distribution of the nerve with tingling and numbness. That is, all the features will be depending on which area the prolapse is happening. Based on the site of the prolapse happening, the features will differ. But based on the distribution of root, the nerve root, there will be pain. And the pain will be depending on the distribution of the nerve. And along with that, tingling and numbness also will be present. And the tenderness over the interspinous ligament or lateral to the spinous process over the affected intervertebral space will be present. Lumbar scoliosis is significant and restricted forward flexion, but free lateral flexion. That will be the range of movements. And there will be wasting on the muscle. Then bladder sensibility that will be lost, then retention of urine will be present, SLR test will be positive on the affected side, and LASIK test, that is the hip is lifted to 90-degree with the knee bent and the knee is gradually extended by the examiner, and if nerve stretch is present it will not be possible to do. So the patient will feel pain in the back of the thigh or leg, that is the LASIK test, and that will be positive in this case. You can see in the image. Then investigation, X-ray of spine, myelography, radiculography, all this CT, MRI, all those are the choice of investigations to be done. Then treatment, posture training, that is bed rest to align the vertebral column and minimize the manipulation to recreate the tone of the muscle and ligaments for 2 to 3 weeks. Then hot fomentation, gentle exercise, spinal jacket, continuous or intermittent traction, analgesics and muscle relaxants, intradiscal injection of chemopapin enzyme which dissolves the fibrocartilaginous tissue and nucleus pulposus, then transcutaneous electrical nerve stimulation, surgery like laminectomy or discectomy, these also can be done. That is the treatment. So these are the main diseases which is coming under the disease of spine. So as we have seen in diseases of spine, the first one we have seen is Pott's disease, which is also called as tuberculosis spine, and the etiological agent here is Mycobacterium tuberculosis, which is a rod-shaped, non-spore forming, thin aerobic weakly gram-positive bacterium, and predisposing factors we have seen, and the commonest site is the uh, lower thoracic region, and the types we have seen: paradiscal, central, anterior, and posterior. Then pathogenesis we have seen in 6 steps. Clinical features when highlighted: 2 stages were told: active and heal stage. Then the examination, the gait, attitude, and deformity, the swelling, tenderness, all these have to be seen. Investigations and treatment to be done, means both conservative as well as surgical management. Conservative include the anti-tubercular treatment, and surgical, it is decompression, debridement, laminectomy, etc. That was about Pott's disease. Then next was ankylosing spondylitis. As already told, it is the chronic inflammation in the axial structures like sacroiliac joint, spine, anterior chest wall, then shoulder, hip, etc. Then we have seen the clinical features present in the condition, that is there will be malaise, fatigue, early morning stiffness, pain in the back, bamboo spine, the stiff spine will be noticed. Plus test we have seen, SLR test will be positive. Then the types: true ankylosing spondylitis and false ankylosing spondylitis, 2 types were told, and again true fibrous and bony type is there. Then treatment, general measures, conservative therapy, and surgery were told. And the third one was IVDP. There will be a protrusion of the pulpy inner material of the intervertebral disc through the fibrous outer core, causing pressure on the adjoining nerve roots and ligaments. Causes: it can be external, internal, physical illness, emotional stress, disc degeneration, etc. Common site is lumbosacral region, and cervical spine also is involved. Posterolateral type and central posterior type are told. And features: based on the distribution of the nerve, based on the affected intervertebral space, the pain of the site of the pain will be differing, but pain, tingling sensation, numbness, restricted movements, wasting, these are the main features told in IVDP or slip disc. Investigation, X-ray, MRI, CT, all those can be done. And treatment, posture training, support, spinal jacket or traction can be done. Then analgesics, intradiscal injection, transcutaneous electrical nerve stimulation, laminectomy or discectomy. These are the other treatments told in IVDP.